Assalamu alaikum. Let's talk about giant cell arteritis. If we think about giant cell arteritis, according to the ACR criteria, American College of Rheumatology 1990 criteria, for giant cell arteritis to diagnose, it requires three of the following GCA diagnosis: age more than 50, new onset, new onset localized headache, new onset localized headache, and temporal artery tenderness and temporal artery tenderness, or decreased pulsation and ESR more than 50. So age more than 50, ESR more than 50, new onset localized headache, temporal artery tenderness, and 5 is temporal artery biopsy. Temporal artery biopsy should be positive. So these are the things we need to consider to diagnose a case with giant arteritis or temporal arteritis. So if I um, tell it again, it requires three out of these five criteria. American College of Rheumatology criteria 1990, that age more than 50, yes sir, more than 50, temporal artery tenderness, temporal artery biopsy is positive, and new onset localized headache. If the patient has uncomplicated giant cell arteritis, what does what does uncomplicated means? Uncomplicated means that no visual involvement. No visual involvement means uncomplicated either or jaw or tongue claudication. So if it is uncomplicated, we can give oral prednisolone, oral prednisolone, 40 to 60 milligram daily until symptoms and investigation become normalized. If it is for uncomplicated and for complicated cases, that means with visual involvement in or jaw or tongue claudication, we can give IV methylprednisolone. We can give IV methyl prednisolone. We can give IV methylprednisolone 500 to 1000 milligram for 3 days followed by oral prednisolone. We know that GCA requires long-term steroid therapy, so we need to give some bone sparing agent and a bisphosphonate and a vitamin D and a gastroprotective drug like omeprazole should be given. For a GCA, these things should be considered. Also, low-dose aspirin should be considered as it has shown to reduce the rate of visual loss and cerebrovascular accident in the GCA. So, for if you are successful for diagnosing a case of GCA, you should consider these drugs also. So, as you are giving steroid for prolonged period, for you are giving steroid up to normalize the labs, the ESR, So you should keep bisphosphonate and vitamin D, bisphosphonate and vitamin D, and some gastroprotective medication like proton pump inhibitor should be prescribed, and we can add low dose aspirin, and it should be considered because it reduces the rate of the visual loss and cerebrovascular accident. So if we think about giant cell arteritis, if you think about the features, typically age more than 50, yes, or more than 50, there may be it may be rapid onset, usually rapid onset less than 1 month, and there may be headache, jaw claudication, and vision testing is the key investigation in all patient. Vision testing is the key investigation in all patient with temporal arteritis, acute ischemic optic neuropathy uh, accounts for the majority of the ocular complication. It results from occlusion of posterior ciliary artery. Occurs due to occlusion of posterior ciliary artery, which is a branch of ophthalmic artery, and there may be ischemia of the optic nerve, and fundoscopy typically shows swollen pale disc and blurred margin. So fundoscopy typically shows uh, pale disc and blurred margin. There will be temporary visual loss, amaurosis fugax, and permanent visual loss is most of the feared complication of the temporal arteritis and may develop suddenly. And diplopia may also result from the involvement of any part of the oculomotor system. So diplopia can happen if there is involvement of the cranial nerves. So AION can happen, acute ischemic optic neuropathy, and it is associated with PMR, not physical medicine and rehabilitation, polymyalgia rheumatica, and it can come also with lethargy, depression, low grade fever, anorexia, and the weight loss. We know that for investigation, ESR more than 50 and CRP may be elevated, and temporary biopsy is the gold standard test for giant cell arteritis, used to confirm the presence of the granulomatous inflammation with a multinucleated giant cell in the temporal artery. Positive biopsy for the diagnosis of the GCA justifies continued corticosteroid therapy, particularly in case with atypical or isolated symptom. If biopsy is negative, so GCA cannot be ruled out because the possibility of the skip lesion. So clinical judgment should be considered. Temporal artery color Doppler ultrasound is a diagnostic alternative. So we can do temporal artery color Doppler ultrasound, which is an alternative of a biopsy. CK and EMG will be normal. CK and EMG will be normal. So if high dose corticosteroid should be given as soon as it is suspected because the temporal before the temporal artery biopsy. So we should give high dose corticosteroid before the temporal artery biopsy. If there is no vision loss, high dose prednisolone is used. If there is evolving vision loss, IV methylprednisolone is given prior to starting high dose prednisolone. So if there is evolving vision loss, IV methylprednisolone should be given before starting the high dose prednisolone. There should be a dramatic response. If not, the diagnosis should be reconsidered. So other thing for bone protection, bisphosphonate is required as long tapering occur of the steroid is required. Low dose aspirin is sometimes given to patient as well, although the evidence based supporting that this is weak. So low dose aspirin can be given. We should do some bone protection giving bisphosphonate and the vitamin D, calcium. So that is all about giant cell arteritis. It's a very high yield topic. Hope you enjoy.